5 p.m. so we get started. So welcome everyone. Thanks for joining and a Happy New Year, even if it's running already for a while. Hope everyone's healthy and stays healthy. Yeah, today we have two very interesting papers related to strain imaging again, which is quite a hot topic in our community. And yeah, let's just begin with the first paper presented by Alicia Maceira from Valencia, which is about detection of subclinical myocardial dysfunction in cocaine addicts with feature tracking cardiovascular magnetic resonance. So the floor is yours, Alicia. Thanks for joining.
Thank you, Tina. I think this is it. Can you see my?
Yes.
All right, good. Okay, so I will talk about detection of myocardial dysfunction in cocaine addicts with preserved systolic function. And this is a paper published last year, which comes from a study we did on cocaine addicts back in 2014. And for that study, we included 94 cocaine addicts with no exclusion criteria like diabetes or claustrophobia or any other known cardiac condition. And we studied them with the conventional CMR analysis we could do in 2014, which was ventricular volumes and mass and ejection fraction, both left and right ventricles, and late gadolinium. And we observed a roughly 71% prevalence of cardiac involvement in asymptomatic cocaine addicts, mainly left ventricular hypertrophy and systolic, mild systolic dysfunction. That was what we found. So 2 years later, we got the strain analysis software. So we decided to analyze cocaine addict with strain analysis. And so we did this study, and we included the same 94 subjects. And we analyzed left ventricular and right ventricular strain and strain rate and desynchrony index in all of them, and in a group of healthy controls. And the cocaine addicts were classified according to their left ventricular ejection fraction, both in preserved ejection fraction and depressed ejection fraction. So we had, don't remember exactly the numbers, but it was more or less equilibrated groups. So we had 30 controls. Let me just check, and it's easy then. Okay, there we are. 30 controls, 62 cocaine addict with preserved ejection fraction and 32 with depressed ejection fraction. And so there were no real differences according to with regard to biological data or laboratory findings. We also included or represented the characteristics of their cocaine addiction, and there were no differences with regard to time of addiction or time after last use. You probably know that in addicts it's very difficult to categorize their severity of addiction. So when we talk to people managing this kind of disorders, they probably don't use the same parameters we would use. So it's not how much cocaine did you have last month or last 3 months, but how long have you been taking cocaine, how much is your peak, and what different parameters, the ones we would expect as a cardiologist. But anyway, there were no differences in the characteristics of their addiction, and neither were differences in characteristics of their alcohol addiction or smoking situation. So again, we examined volumes, ejection fraction, mass, late gadolinium, presence of edema, and you've got the results here. So there were differences, obviously, between controls and cocaine addicts, and among the two groups of addicts with regard to volumes and mass and ejection fraction. And these are the graphs. And when we analyzed the strain, we observed significant differences, as expected, among the three groups with regard to all parameters. Yes, all parameters, except for left ventricular circumferential strain rate. And in the post-hoc analysis, we observed that cocaine addicts with preserved ejection fraction had left ventricular longitudinal, radial, and circumferential strain, which was intermediate between the controls and the cocaine addict with depressed ejection fraction. And it was the same, most surprisingly, for the right ventricle. And it happened something similar with the dysynchrony index. So cocaine addicts with preserved ejection fraction had an intermediate values between normal subjects and cocaine addicts with depressed ejection fraction. There were no differences in late gadolinium enhancement. There were no differences in left ventricular hypertrophy or in stress perfusion in the group of subjects in which we had carried out a stress perfusion at the beginning, so 4 years ago. So, well, just briefly summarizing the paper, we concluded that a strain analysis could show some early subclinical dysfunction in cocaine addicts who did not have depression of their left ventricular or right ventricular ejection fraction. And well, that's mostly the paper. Thank you.
Yeah, thank you very much, Alicia. I think it's a very interesting paper. So it's a special patient group. And what are your thoughts about the clinical relevance of the strain parameters in this special patient cohort? Do you think it's, it will be part of routine clinical workup in the future, or what do you think?
I don't really know. We're still studying cocaine subjects, cocaine addicts, and we are doing strain. I don't know in your part of the world, in Spain where I live, usually cocaine addicts, when they go to rehab, they don't even get a proper cardiac assessment. Either with echocardiography. So this was a research study and part of PhD. So we did it in these subjects for research, but in clinical practice, they don't get a proper cardiac assessment. Neither with echocardiography, of course not with CMR, and it would be, I mean, it's unthinkable here to do strain analysis in these subjects to see whether they're going to develop in some point ventricular dysfunction. Also, we don't really know whether this depression of strain parameters might indicate that they are going to have systolic dysfunction in the long run. So, from a clinical point of view, I don't think we will, I mean, this will be implemented in clinical practice because it's a matter of funding and, I mean, we're short of this here. But from a research point of view, I think it's interesting and it's something we're still working on.
Okay, thank you. Matthias, you have a question. Do you want to unmute yourself?
Sure. Yeah, thank you very much, Alicia. So my my question is, there is a method called long axis strain, where you just look at the shortening of the long axis between mitral valve and apex as a surrogate for the global longitudinal strain. Since this is much easier, and there are some papers even showing a prognostic impact, what is your take on that, comparing this method with the global longitudinal strain as measured through the methods that you used?
Do you mean ABPD? So ventricular plane displacement, or
yeah, so that's one way to look at it. We had the MAPSE and the APSE. Yeah. So, but in fact, that was just on looking on one end, but you have to look on both ends. So the apex and the valve, and how this shortens. Yeah. And there have been papers from Heidelberg and from some other centers showing that this method may be very predictive of outcome, and this would kind of be a very global assessment of the longitudinal strain, because it's the shortening of the ventricle, basically.
Yeah. It's it will be easier to do, and probably very informative. But then you're not really getting all the information of the myocardial dynamics, like the circumferential, the torsion, and so I can't really answer your question. I would need to check, to test it.
Yeah. Okay. Thank you.
We have another question in the chat, which is, what is the pathophysiological cause of the impairment? Is it ischemia or interstitial fibrosis? And the second part is it reversible after withdrawing?
Yeah. We are still, we haven't finished it because of this COVID crazy thing we have now, but we are analyzing the follow-up of these subjects. We repeated the CMR scan sometime after the first scan, so we've got 2 time points in them. Now at this point, all I can say is that it's very difficult to get an answer, because the main point we need to clarify is whether the patient has quit cocaine or not. And not all of them. I mean, we had 94 after 1 year. I think we repeated the scanning, half of them, and less than half had quit cocaine. So if they haven't quit cocaine, we can't really withdraw any conclusion. And regarding what is the pathological mechanism, we don't really know. I mean, little is known about how cocaine affects the heart, and several mechanisms have been proposed, like ischemia, but in the subjects we did stress analysis, we didn't find any perfusion defect. I mean, there were no significant differences in perfusion defects between those with normal function and without normal function. Other mechanisms that have been reported are a direct toxic effect, myocardial inflammation, toxic effect of the substances that come with cocaine when they uptake the cocaine. It's not pure cocaine, but mixed with other things. So, I mean, it's probably a multifactorial mechanism. One of the important things is that when cocaine is taken with alcohol, the effect, the toxic effect is more intense. So that's another factor to take into account when analyzing this habit. So it's really multifactorial. We can't tell, in my opinion.
Okay, so yeah, it's a very interesting topic, I think. So yeah, we have reached 15 minutes. So thank you very much, Alicia, for presenting your paper. It's very interesting work. And yeah, then maybe you can stop your presentation on screen sharing, and we move on to the next speaker, who is Andreas Kammerlander from Vienna. Thank you also to you, Andreas, for presenting today. And it's another interesting strain paper which deals with the risk stratification potential of strain in HFpEF patients. So
thanks for the kind invitation. So everyone who does not know me, my name is Andreas Kammerlander. I'm with the cardiology department of the Medical University of Vienna. This paper was accepted when I did a research fellowship with Udo Hoffmann at Mass General in Boston. So thanks to this group for giving me some extra time and not being on night shifts. So the topic is feature tracking of global longitudinal strain on CMR, improves risk stratification in HFpEF patients. I will skip the abstract part. I'll come to that later on. So for the background, as you know, heart failure with preserved ejection fraction is a common entity. It's almost as prevalent as heart failure with reduced ejection fraction and has very dismal outcomes with mortality, 5-year mortality rates reported up to 75%. And no treatment so far established. So all large trials failed to show improvement. So the current ESC guidelines stratify heart failure based on the left ventricular ejection fraction into reduced, mid-range, and preserved subtypes based on the thresholds. As you know, 40% or lower is reduced, between 40 and 50% is a more novel entity of mid-range ejection fraction, and the preserved ejection fraction now is defined as LVEF greater or equal to 50%. And this is the group we're looking at. And this definition, this very recent definition based on left ventricular ejection fraction, of course, has some downsides because we know that systolic function is not only the ejection fraction, which just tells us the difference between end diastolic and end systolic volume. And you're very familiar with the concept of strain, which is a dimensionless index of the change of distance between 2 points. And there have been numerous studies showing that, echo studies, showing that primarily the global longitudinal strain may supersede LV ejection fraction in a lot of cardiac conditions. So on echo, there's very good evidence that it makes sense to do strain, and it might be better than ejection fraction for evaluation of systolic function. With CMR, it only has been recently that feature tracking has been introduced to provide strain analysis in a very similar way to echo. As you know, CMR is a gold reference for ventricle volumes and ejection fraction assessment. We have this great tool of non-invasive tissue characterization using T1 mapping, which is really unique and cannot be provided by echo. And we have a center where we try to scan all HFpEF patients. And we wanted with this study to basically look at 2 things. First is MR strain, and we focused on longitudinal strain associated with T1 mapping results. And secondly, does it predict outcome? So very briefly about our center, we are at the Medical University of Vienna. We have a prospective registry, including all HFpEF patients. Now we have some 600 patients or so. Back then it was 300. The diagnosis of HFpEF, we follow the guidelines. This was the back then definition, but actually nothing really dramatic has changed. You have to have signs and symptoms of heart failure, which is most dominantly leg edema and dyspnea on exertion, ejection fraction greater than 50% on echo, elevated BNP levels, and signs of diastolic dysfunction on echo, or hypertrophy or left atrial enlargement, which is usually always present, at least to those patients referred to us. We also do in a fair amount of patients right heart cath to confirm the diagnosis of diastolic dysfunction in these patients. And I think it's worth to mention that we exclude cardiac amyloidosis in each of these patients. And for outcome measures, we decided a standard outcome parameter: heart failure, hospitalization, and cardiovascular death in this cohort, which is very routine way to do. All patients had an echo before study entry to establish the diagnosis, of course. So I'll not go into detail with that. And then for the CMR protocol, it was a standard CMR protocol, actually, including Mali for T1 mapping on a 1.5 Tesla system. And we did post hoc analysis for this study using CR42 sort of Circle CBI software for strain analysis using a stack of short axis views and then a 2-chamber, 3-chamber, and the 4-chamber view. And the software gives you the 3D results for peak longitudinal strain, peak circumferential strain, and peak radial strain, as you probably all are familiar with. And these were the parameters we were interested in. So yes, for the statistical analysis, I think it's worth mentioning the Cox regression. We did two approaches. First, we corrected the strain analysis for all parameters that were significant on a univariable level. And secondly, we defined a set of risk factors we know is important in these patients, which is age, sex, BNP, LA size, RV, ejection fraction, and RV size. And wanted to see if by adjusting the strain parameters to these risk factors, if there is a significant risk prediction by the strain parameter. So this is the cohort we were looking at. We started with 278 screened individuals, excluded for a bunch of reasons like pacemaker, ICD implants, claustrophobia. Then had 216 patients scanned, and we excluded 10 for insufficient MRI quality, ended up with a final cohort of 206. And since global longitudinal strain and CMR is not really established, we divided the cohort based on the median, which was minus 8.5%. As you can see here, so on the left part, you have all participants, then you have minus 8.5 or less. So this is actually the better systolic function, and then the worst systolic function, which is strain greater, so more positive value, the minus 8.5%. And you can see a bunch of differences. First, there were more women in the or better strain values than in the worst strain value cohort. Atrial fibrillation was associated with more impaired strain values. BNP values were higher, LE size was higher, RA size was higher. Interestingly, no difference in the left ventricular end-diastolic volume or the RV end-diastolic volume, because you would suspect in HFpEF patients, those who are sicker actually have more dilated RVs. At least that's what we think clinically. There was a difference in the LV ejection fraction, which was not that surprising. There was no statistical difference in the extracellular volume. And just to keep in mind, HFpEF patients is usually elderly female patients. This is so the mean age was 71, and the mean proportion of female individuals was 70%. So this is a tip. Here we see the correlation between ECV, extracellular volume, on T1 mapping, and the global longitudinal strain on CMR. And you see it's significant, but it's a very low correlation between these two parameters. This was the first aim we wanted to answer. So there is an association, but we are not measuring the same thing by these methods, obviously. It's interesting, we had, so more than 50% of individuals had an event. I think 109 of 206 patients had an event with 30 deaths. So this is a very sick cohort. And what we can see is dividing by the global longitudinal strain median, you have a significant separation in the Kaplan-Meier estimates. So with a log rank with a p smaller than 1. And in the Cox regression analysis, and this is the first set I explained earlier, this is on the left side, you have the univariate analysis. I won't go into detail with that. I highlighted those that remain significantly after multivariable adjustment, which is age, so it's not surprising, BNP levels, not surprising. RV size didn't make it into the final model, but only just a bit. And global longitudinal strain was significantly associated despite adjusting for very strong predictors such as age and NT-proBNP values. So this was the first adjustment set, and then the second one was a predefined one where we see the same result, but only here the RV size made it into the final model. But here age, NT-proBNP values, RV size, and global longitudinal strain have had a significant impact on outcome. Now you see circumferential not in the parameters were in the multivariable model, and that we added global longitudinal strain, and in the next model, circumferential strain and radial strain. So we did not include all strain parameters into the same model. Yeah, so strain seems to be important in this cohort. And when we take a look into mainly only echo studies that have been done in HFpEF patients and looked at strain, we see that there's a bunch of studies indicating that this might be a very good target and predicting outcome. But there are also 2 studies actually where strain failed, and those were studies that included BMP values and were actually had tougher multivariate Cox regression models. So ultimately, we don't know the value of global longitudinal strain in HFpEF. And again, these were echo studies. We know echo has several time. And feature tracking CMR is an extremely cool tool, but we have very limited experience with that, especially in HFpEF. But the cool thing is that right ventricular function is extremely important in this cohort, and also T1 mapping is very interesting in these patients. So CMR here really adds now the novel technique of strain analysis, and it seems there's a lot of information inside. The previous studies on feature tracking CMR at the time of when it was published, were mainly focused on non-ischemic cardiomyopathy and myocardial infarction cohorts and heart failure with reduced ejection fraction. So this was really one of the first studies investigating feature tracking on CMR in HFpEF. And so what we conclude is actually that global longitudinal strain of the LV on CMR adds to the portfolio of this emerging technique. And I think this is really that's the most important message we can get out of this study. So yeah, thanks. And I'm happy to take questions. I'll display the abstract if there are any questions, and thanks for your attention.
Yeah, thank you very much, Andreas. It's a very interesting story and a very interesting paper, I think. So we have some questions in the chat. The first one is, did you find a threshold of a GLS value for your HFpEF definition that predicted better than the definition of HFpEF itself?
Yeah, that's a good question. I mean, for that, we are interested in this, and we want to look at that in a larger cohort. It's a little difficult with this cohort because we know the patients we see and enroll are already on the very end stage. You see it in the event rates. We have more than 50% event rates, which is great if you do studies in these. Not
sorry, we have some dropouts. Andreas,
oh.
we have, sorry to interrupt you, but we have some dropouts in your connection. Maybe you can switch off your video, then maybe it will get better.
I'll stop sharing and I'll stop the video. Can you hear me better?
Yeah, currently, yes.
Okay. So that is an interesting question, but the problem is the population we have is a very sick one. So we see patients at a very late stage of their disease. We want to look at that by recruiting more patients at an early stage with lower BMP values, and then maybe see if there's a threshold of where GLS really can put us forward.
Yeah, I see. I agree. We have another question, or 2 questions, which are related to the relation between strain and mapping. So first one is the relation between strain and T1, T2 mapping, and Matthias added to that that myocardial edema might also play a role in HFpEF, and he asked if you also looked at T2 mapping.
Yeah, so we started doing T2 maps after that. So I think in 2015, 2016. So we don't have, so in the patients we scan right now, we do it, of course, but we have too little data on that. For the T1 mapping, there is some correlation, but it's a weak one. And I don't think we're measuring the strain. I'm not sure if strain really gives us, I think it's, yeah, it seemed, I expected more correlation because for me, it would make sense. A lot of fibrosis, a lot of impaired longitudinal strain. That would be my concept in my head. It seems it's not that easy. So it's a very low correlation. Yeah.
And we aren't really sure if we see really fibrosis when we look at T1 values. So maybe we see something
absolutely.
else, and this explains the modest correlation between the two. Yeah.
I mean, we did biopsies in these patients too, so we do know there's fibrosis definitely is an issue. So, but of course, with T1 you get it all, but you don't know which specific compartment actually is altering the signal. I absolutely agree.
Yeah. Matthias, do you want to add something to your question?
Yeah, thank you. So first of all, thanks for your presentation, a great paper. So do you see a role in differentiating systolic from diastolic strain parameters, things like strain rate, because HFpEF to some extent probably is a disease. That's why I brought the edema in. We have seen that the T2 was on average higher in patients with HFpEF, even if they were not currently symptomatic. And edema would explain the restrictive physiology that we observe in these patients. Some of that, of course, happens more on the diastolic side than on the systolic side. So that's why I have the question, do you think that we should have another focus on differentiating between the two?
I mean, it would be extreme. You get the software gives you the diastolic strain rate and a lot of parameters. Having the title diastolic in it, I have to admit, I'm not too sure what exactly I'm measuring with that. I'm interested in the data. Probably I don't understand it to the full extent. I'm surprised that the longitudinal strain has this remarkable impact on outcome. And I think it's hard for the community. I think it took a long time to establish LV ejection fraction to get it in every echo report, and it still is not the case. It will be even a long way to go to put a global longitudinal strain in the echo reports, although it's a very established parameter there. I think there it really splits into the research only. The clinical application, I think global longitudinal strain could very soon be implemented, and also like sub-definitions of heart failure. And maybe I think the most important thing is to identify individuals or patients who benefit from specific treatments, because as we know, HFpEF is such a heterogeneous entity. If we can better define the subgroups by maybe global longitudinal strain, and show that a certain amount of individuals benefits from a treatment, I think then it really opens a new chapter. We are looking in the diastolic measures by CMR. Although again, I have to admit, I'm not too sure what I'm measuring there.
Yeah. Okay. So
yeah.
Thank you very much.
Yeah. Well, I hope we can continue that at some time.
Yeah.
Yeah, I'd love to. It's a great.
Yeah. So I'm sorry to interrupt the discussion because we are already 3 minutes over time, and Matthias for sure wants to give an outlook for the next CMR Journal Club. So I hand over to you.
Yeah. Thank you very much. So I just wanted to announce the Journal Club on February 3rd. So we will talk, and I will have to share my screen here. I hope you can see it. We will present 2 papers, and because we're in the second wave of COVID and it hits us all very hard, I thought it would be time to revisit that topic, and a lot has happened in between. We have a much better understanding what COVID does. We also have learned that we do not well understand what COVID does in the long run. So that's why I think we have to go back and look at some of the papers. And one of them was from Oxford. This is the one published in the Lancet publication in Clinical Medicine on medium-term effects of COVID or SARS coronavirus infection on several organs, among them the heart. So the very interesting paper. And then from Italy, from Marco Francone's group, a suggestion how to perform a cardiothoracic MR imaging scan in COVID-19. That's kind of a comprehensive scan that includes lungs and pulmonary arteries. So I think this is extremely interesting. So I hope you can join on February 3rd, and see you then.
Yeah, thank you, Matthias. This sounds really exciting. I'm looking forward to February 3rd. So thank you again, Andreas, for presenting your work. Thank you all for the discussion and for joining, and yeah, stay healthy. See you on February 3rd. Have a nice evening. Bye-bye.
Thank you all. Bye.